folks. How are you today? We've got myself, Judy Thompson, Jocelyn Hill, and Blake Hotchkiss. Say hi, guys.
Hey.
Hi.
So we are not starting the webinar early. We're just, we saw a bunch of you here and we decided we'd start a little bit of a chit chat. So what we're gonna do, I think, is show my screen so I can at least show you a little different. We're gonna start with a couple polls. And during these polls, just answer however you feel. There's some that are one answer, some that are two, but and then we'll get your feelings on some things. Then we'll get into the presentation here in a couple minutes. So Blake, you want to kick off number one?
Awesome. Let's get this poll started. Do you have IV drug using patients as part of your practice? Yes or no? Yes.
That's great.
Shoot off for number two.
Do you have a vascular access strategy for this population? Safety, policy, etc. Yes or no? And 60% of people said that they don't have any special policies or strategies to help mitigate risk in this population. So, do you know someone struggling with addiction? Click all that apply.
Oh, okay.
So it could be family member, friend, spouse, partner, coworker. Getting right over 50%. Let's close the poll. Share those results with you guys. So 41%, highest category for family member, 37 was other, and then followed by friend or coworker, and then a spouse or partner.
So we're all struggling. Everybody knows someone somewhere that it seems that has a problem with drugs. It's rampant.
That's great. That's great feedback.
Do you have access to Narcan? Click all that apply. So it could be at work, at home, or no. And this is an interesting one for me while we're waiting for the percentages. I know that in Bangor, Maine, where I used to work, we had a community program where the police had Narcan. We were dispensing, used rabbit ears for that, Narcan as part of a community outreach program because of addiction, changes in policy, and helping to reduce the risk and loss of life in that population.
Right.
Do you have access to Narcan? We got 59% yes, and then followed immediately by no, don't have access.
40%. Wow. Yeah. Okay. That's a very interesting stat. Thank you.
Now it's my pleasure to introduce our speaker, Jocelyn Hill. So she is a clinical nurse specialist working in IV therapy, vascular access, and home infusion programs in Providence Healthcare in Vancouver, British Columbia, Canada.
Oh my God, where did you get those photos, Judy?
Oh my Lord.
I stalked you on Facebook.
Oh my God.
AVA Board of Directors, President-elect for 2020, Vancouver AVA Network and CVAA Chapter President, founding and current. She's also been on the CVAA Board of Directors as the past president, as well as the VAC Board of Directors, the past director at large. She is a proud Canadian mother of 2 kids who hate it when they yell on the sideline. Oh, when she yells on the sidelines at their soccer games. If they listen to me, I would stop yelling. Okay. My favorite part here in the intro slides was the life motto: when in doubt, buy the shoes and eat the cake. And I'm gonna.
Thank you, Blake and Judy.
I need to add a little context to this image. Actually, Jocelyn, maybe you could. No? Okay. Well,
Thank you very much, and thanks everybody for joining us today. I know that we're all kind of consumed and busy with other things in work, so this is a topic that is very near and dear to my heart and very relevant, even based on what's happening in our healthcare and clinical practice today. We are going to talk about harm reduction and ethical issues, and specifically dealing with patients with vascular access challenges. These are my disclosures. The companies that I work for or do consulting for have not been involved in the development of this presentation, and I am a full-time employee at St. Paul's Hospital in Vancouver, BC, Canada. Okay, so the objectives for today, thank you for submitting those poll question answers. It's very helpful and hopefully can facilitate a lot of the discussion we're going to have here today for the next hour. Basically the three objectives, we're going to talk about ethics and harm reduction theory in general, and then link it to how it's relevant to what we do as vascular access specialists. We're going to talk about ethical dilemmas when considering harm reduction theory that can be quite complex and not as simple as some of us would like it to be. I really believe that as someone that's practicing with this patient population. And then I'm going to talk about specific strategies that we are employing here in Vancouver, Canada, recognizing that the healthcare systems in the United States and Canada are different. But I'm hoping to just shed some light on some innovation and thinking outside the box on what we can do with these patients with substance use disorder, drug use disorder, and really the whole complexity of their medical and personal situations. So current events, and these are old stats, and it's really, I think, old news because of basically what's happening in the world today. It is still a crisis, and what we're finding here in Vancouver, where a lot, there's a lot of areas in downtown Vancouver that are known as ground zero for this issue, despite what's happening with COVID and the trying to flatten the curve, et cetera, and all the other things that are happening. This is a patient population, or these are people that are, unfortunately, we still have to treat them, we still see them, and they still deserve our care. So despite what's happening in current events and news, I really believe that looking at strategies and thinking outside the box for vascular access in general is still really important. So when we talk about substance use disorder, and I know a lot of us really refer it to as IVDU or IV drug use, what we try to do here in Vancouver is try to reduce the stigma and the negative implications as much as possible. We're trying to get away from the verbiage and language of abuse. It really is a disorder and use in general. It's really important to understand that people that use substances and have negative outcomes because of it, they aren't necessarily addicted as we know it, and it really is defined in the Diagnostic and Statistical Manual, and it has been since 2013 as a disorder. So the stigma around the word abuse is very negative, so we try to get away with that, from that, and use things like SUD or substance use disorder instead. We're seeing it, a lot of literature now and a lot of the scientific evidence looking at it as a chronic disease. And this really helps us strategize and intervene in different ways than what we're used to in terms of punishment and, a Band-Aid solution to something that really is a chronic disorder. There's other chronic diseases that we could maybe consider when we talk about substance use disorder, like cancer, diabetes, cystic fibrosis, congestive heart failure. There's many, many other chronic illnesses that we deal with and strategize around as clinicians in a very different way compared to what we do with substance use disorder patients. So that is something that we really need to think about as clinicians and specialists, and how we can improve patient outcomes and care in general for the whole population, and not just siloing and siphoning off, best practice in other areas. And so Blake alluded to during the poll question period there about other substances. So these are substances that are commonly misused, commonly if they are used inappropriately or in excessiveness, we will see negative patient outcomes. And it's just not about opioids or heroin and opium. It's also about alcohol. Alcoholism is a huge disorder, a huge issue in our practice that we need to deal with, and we have strategies to intervene and help patients with that. We look at tobacco. We've had huge national and international programs dealing with nicotine use and trying to get people to stop smoking. There's so many other things other than what people are injecting into their veins that we are seeing as substances that are misused.
I could not live a day without using. Shame and guilt, anger and resentment. That's a feeling I never want to feel again. But everybody deserves compassion and care. Know that you are worth it. Recovery is real. Recovery is possible. It takes a lot of strength and a lot of courage to be able to do it, but you can get through it.
In our province, and it really meant to highlight and there were other people interviewed and who spoke in that commercial advertisement, and it was really meant to show the different types of people that we encounter in the system, in the healthcare system, as patients and as clients in different recovery homes, etc. And this is some more recollections and voices of actual patients.
Even to this day, I don't wear t-shirts in the summer because of the stigma around injecting drugs. The first time I went to get a blood test to start on methadone, the nurse or the technician was having problems finding a vein. She asked me how I could do this to myself. I was embarrassed enough as it was. I really didn't need to hear her saying that. There are some hospitals and clinics in this city that are really good, and some that aren't very good towards people that use drugs. Some of the things they said to me in regards to the infections I had when I was using IV drugs, they were just horrible.
And again, hearing from actual patients or clients that we encounter really helps emphasize on my practice personally and some of the assumptions and judgments that we make every day. And just hearing their voices and seeing it out in public and their bravery and how strong they are in actually speaking about it really helps me in terms of as a vascular access specialist and as a clinician to do a lot of reflection, especially when I come to work every day and I really don't know who is going to have substance use disorder right off the bat. And I think it's something that it's very important to step back and really consider. I don't know what's happening initially when I see these patients, and we make a lot of assumptions. So with all that in mind, it's really important, like I said, to really reflect on what your own values and what your own ethical stance is, and trying to put judgments and assumptions aside. I think every day in our practice, we come upon an ethical dilemma. And I think even with COVID-19 happening, worldwide, there are some ethical issues that have come up also. But reflecting back on, a specific patient population with substance use disorder, I think there are assumptions and judgments that we make without even thinking about it. And, hopefully this presentation will help and, to see the other side of it and to consider how you actually practice directly. So we all have a code of ethics. We all go into the specialty either as a nurse, a physician, a paramedic, a pharmacist, the whole realm of multidisciplines in our healthcare system. It's pretty straightforward what is at our core. And we want to promote health and well-being. We want to promote justice. We want to honor dignity. Even if you're not using these words and even if you're not thinking these words, I think every day we go into work or every day that we try to do something with our patients or with our practice, this is what is at our core. And these are the nursing association ethics. And if we look at the medical ethics, It's very basic, and again, very aligned with what's happening with the medical specialty as well as the nursing specialty. Justice, autonomy, beneficence, and non-malfeasance. So it's a hard, I really believe these principles can be difficult to balance. For justice, is it really possible to provide fair care all the time? And when we talk about that, it's about equal distribution of therapy and treatments. Who gets seen first? Who gets what first? When we talk about autonomy, we have to remember that the patient has the right to reject or refuse. And passing judgment or trying to coerce them, and I've been guilty of that myself, trying to convince them that they need that, that line or those antibiotics. They still have that right to refuse. Obviously, we're going to do our best to, to talk to them and provide them with all the explanations and reasons why they need treatment. But again, every patient deserves autonomy. Beneficence and malfeasance, I think we all strive to do good. And we're going to talk about some fundamental situations where it really is relevant to us as vascular access specialists. So let's get into harm reduction. And this is where it gets very interesting, because I think harm reduction is a term that everybody is just, flippantly talking about, and we say we're utilizing harm reduction theories or policies and procedures. But what really is harm reduction? It actually was a modern day movement that was formalized in the UK, but it actually started in the 1960s. And as you know, it is all over the news. It's nothing. Everybody has heard of harm reduction, but it's just how it entails to your practice is maybe that's something that could be shared and looked at differently. It is evidence-based. But it also is not just for drugs that we're talking about. It is just not for substance use disorder. There's many other strategies and ways that harm reduction is utilized for the general health of population. It is a public health approach, and it is really meant to benefit the whole society. And I think this is what's really important when we talk about the challenges that we have as vascular access specialists, as healthcare clinicians. It's just not about us, and it's just not about that one patient. It is about the whole community and as a society. So in relation to substance use disorder, there's some principles of harm reduction that obviously there's so much detail and there's so much literature and theory about it. But in general, I think to be pragmatic, we need to be part of the solution, not facilitating or adding to the problem. We need to focus on harm and not necessarily the use. We need to encourage safer practice. And again, here in Vancouver, we are very fortunate to have resources and specialists that are really focused on harm reduction in terms of those safe practices. And it's not just about abstinence, and it's not about just replacing it. It's really more about maximizing what the person or the patients are able to do. We want to keep them alive and safe, but how we do that is very important. Decreasing the stigma and not using, or not coercing and not using our own judgment in terms of how we care for them is really important. We need to understand where the person is. And I think a lot of us, especially on my team here, sometimes struggle with that, because each patient that we see that is struggling with substance use disorder is at a different phase in their drug use journey. Obviously, we want to get them to a safe and hopefully not using phase, but sometimes it's just not possible. So how can we do that using harm reduction theory in relation to vascular access? So the spectrum, this is an example of what we had to look at in terms of safer injection. Obviously, everybody wants to strive for the green light there, no harm, nobody is injecting, and complete abstinence. We realize very quickly, if you're ever looking at that strategy, that there is a high failure rate for that. The lesser harm, obviously, is using in a safe environment with safe and sterile supplies. Now, for a lot of people, as you see there, they may think that is still very harmful. But if we move down the spectrum there, the red dot here we don't want people sharing and reusing. We don't want them disposing in the parks or public areas. These people need to have access to the environment that will provide safe practices. And I say that, with quotations, because the practices that they're doing may not really be aligned with, how we feel as healthcare professionals is safe. So our ultimate goal is we need to accept the fact that IV drug use, substance use disorder is part of our world. There are different stages in a journey of someone that is using drugs. And the challenge really is to be empathetic and support these patients in that journey, as well as the healthcare clinicians, as well as the nurses and specialists that are trying to treat them and deal with their acute issues. Again, it's not just about abstinence. It can be a combination of harm reduction and abstinence. Many people feel that the goal is to get to abstinence, but I've learned very quickly in my practice that sometimes that is a very unrealistic goal. So embracing harm reduction in terms of our practice is very important, but also very useful in terms of seeing success. And I think that's what we want to do. So harm reduction in the general public, in public health policy, there's other things that we have done. So it's just not about the drugs again. We use sunscreen. That is protecting us from, very bad outcomes. We all wear helmets, so we're supposed to wear a helmet when you ride a bike or a motorcycle. Again, these are, in theory, harm reduction strategies that have been very successful in terms of public health policy. Seatbelts and airbags, these are things that we take for granted. When we initiated them, and those that are old enough to remember the days before seatbelts and airbags, that transition was very difficult. And I think there is still a generation alive that, can't believe that we have to have a seatbelt or it's uncomfortable for them. But if we remember when it was initiated, it was just a international or a national implementation. And now you cannot buy a car without a seatbelt or without an airbag. Extracurricular activities. That was a huge strategy for us in distributing safe sex, activities, condoms. I mean, it sounds very simplistic, but this was a general theory of harm reduction that public health policy implemented. And I want to be clear here, I'm not promoting drug use. I personally feel very strongly that we just need to provide safe alternatives for patients. So what we're seeing in our practice, we're seeing high numbers, we're seeing a growing trend. I don't think this is anything new to anyone, but we're also seeing very complex diagnoses and medication therapies and long or inconsistent therapy durations. And that could be based on patient compliance and also access to healthcare. But in the emergency department, I think we are seeing return visits that can be unmanageable, but still we have an ethical duty to still see and treat these patients. We're obviously seeing disruptions in care, especially today in the COVID-19 world. There's a lot of disruptions in care. There's a lot of incomplete therapy with this population that can be sometimes unreliable and non-compliant. So we're seeing increased complications and morbidity with substance use disorder, which is very concerning because with ethics at our core, we should be doing no harm and keeping these patients alive. I think inadequate care in general, from the medical sense, substance use disorder is a specialty. We have an addictions team here that really focuses on the well-being of the patient as a whole patient. So, bringing in different specialties in terms of their cardiac issues, in terms of their kidney issues, et cetera, is very important in terms of the whole strategy for harm reduction. So are we meeting the demands and expectations for quality care? I think on a daily basis, we try to, but I think there's still a lot of work to do in terms of meeting those demands. So our vascular access implications, it all starts out great. This is an actual patient that I think we would all agree would be our dream patient, and every single patient could be like that. But we know that is not the case. The fun starts. We see, limbs and arms and access points that have been really brutalized and accessed way too many times, or accessed inappropriately. And you'll see some of the locations, obviously, of these arms here. It's an issue. When you add IV drug use, so accessing of veins for drugs, it becomes even more complex. And what we see here is the classic tracking. They're trying to track up the vein, different points along the vein, and obviously some simple cellulitis, which can turn very bad, very ugly, very quickly. So the complexity of what we have to see as vascular access specialists, often we are the first line of defense, because the physician groups or the nurse practitioners that I work with, they want to order things, they want to treat, they want to, get things started. But this is sometimes what we have to deal with right off the bat. So it can be very, very challenging as a vascular access team or specialty to find good access. And obviously, in these patients, you're going to look for different points of access. So not just with the tracking of the multiple pokes, but then you get the body art. So they can be very simple, the little Canadian flag or the large Canadian flag. And what we're seeing now is very intricate, colorful, detailed body ink, body art on all areas of the body. So this, as a vascular access specialist, proves very, very challenging, obviously, especially when you don't have access to good technology. And unfortunately, there are still teams out there that I know, or specialists out there, and nurses and doctors that I know that are still, not having access to ultrasound or vein visualization technology. So, but these are the challenges we're seeing, and I think the more that we see of these challenges, I think that is better argument for us to really push for access to technology to help patients and better the outcomes. So technology is your best friend. There are many, many, and I'm not here to promote one or the other, but I really believe that vein visualization technology is important. Whether you could go straight to ultrasound would be fantastic, but I think there are so many alternatives out there that all of us should be educated and have access to some sort of vein visualization technology. So the ultimate challenges that we see is the ethical debate. I mean, we want to care and treat for all, and we want to do that every time. So even when there's a compliance issue or a reliability issue, and even when we're seeing those patients over and over and over again, these people still deserve our respect, our compassion, and empathy. And even despite that, still those devices that we place, they will likely fail, especially if there's a compliance and reliability issue. But, they will not comply, they will not complete therapy. That cellulitis that we saw in the beginning will worsen. How much is too much? I think that initially is our ethical dilemma that goes in our head. We see these patients over and over again. We really struggle to consider, do we treat them? Do we put that PICC line in? Do we, put that peripheral IV line again? We are getting better at it. We're getting better with our language, our patient education, and really it's about the devices that we're using that can really help some of these outcomes. So this is a very common slide. It talks about equality and equity and access to things like therapy, clinical care, clinical specialists. And I really think what's happening here is, in reality, there are some people or some patients that have more opportunities and better care. I'm going to say it right out there. And there's some that don't. And I think providing, as you see there in the equality box, providing, ultrasound in my hands for for every single patient can help, but there are so many other things that could be a barrier in terms of affecting their compliance and reliability, that it's just not about me getting that pick in. It's just not about, the home care nurse facilitating the IV antibiotics. It's really about breaking down barriers that are happening in the environment, the social issues that they are seeing, that we really need to be able to collaborate together with multidisciplines to break down all those barriers so they can see over that wall and that maybe just knock down the wall altogether. Collaboration with social work, psychiatry, addictions medicine, these might be obvious team members for you, but what we've done is we have collaborated very closely with the police and security services, and they actually help us, a lot in terms of trying to manage and, really cooperate with the patient in order to get them to a very good place to ensure compliance and reliability, which means completion of therapy, which is ultimately what we want in the acute situations when we're dealing with vascular access. So again, when we talk about devices, there's me and you as the handler of these devices, but we need to be able to choose wisely for these patients. We have a whole plethora of options. We have the short peripheral IVs, we have the longer peripheral IVs, we have midlines, we have PICCs, we have tunnels, we have IVADs. And I get this question all the time. Would you put an IVAD in a patient that had a diagnosis of substance use disorder? Would you put a tunneled line, a cuffed line in one of these patients? And my answer is, if it's appropriate and if there's no other option, yes, I would. And I think we have to wrap our heads around more about what is the most appropriate vascular access device for these patients and what will get them to the end of their therapy. And if we feel it's a true chronicity of disease for them and that we're going to see them over and over again, a tunneled line may work. A peripheral IV line may work. It's really going to depend on our vessel health and preservation strategies, as well as trying to decide what is the best option. What's really key is securing the line. We put in a lot of lines for all patients, and I think all patients deserve the best securement for any line that we have worked so hard to get in. So typically for patients, based on their therapy and the duration of therapy, we are going to put in a central vascular access device like a PICC line. So things like the subcutaneous anchoring device are absolutely imperative to use in terms of preserving that line for the full length of therapy. So especially if there is a reliability issue and they may miss some doses, at least I know that line is in, and at least I know that it has not moved, and that we can continue trying to, treat these patients using the appropriate medications and not worry about whether it's peripheral or whether it's malpositions, et cetera. So there's many other devices other than the subcutaneous anchoring device, which we use exclusively on our PICCs. There's also the adhesive devices. We have not seen as good success with those, but there's so many things available. Just know what's in your toolbox. So other considerations, especially when it comes to your team or yourself putting in the lines, there could be an aggression, violence risk. The unpredictable behavior can be very unsettling and can cause a lot of anxiety and stress and be overwhelming for staff. But really, I think if you can all see that in the blue circle, we would insert the PICC again, and we would start the IV antibiotics again. We have a very dedicated team in trying to ensure that, the completion of therapy for the full duration of therapy is very important. We do a lot of education, and we've gotten very good at educating them on the risks for PICC use and misuse, as well as for missed doses. So, about dosing, we work very closely with antimicrobial stewardship programs in terms of, I don't know what you call it in the United States, but it's daptomycin, which is a weight-based antibiotic that we use for a once-a-day dosing in comparison to BID or every 8-hour dosing of another medication. But it's very costly. And so, you know, and the spectrum is different for each medication. But working together with your infectious disease physicians and your antimicrobial stewardship program, it can really help target, you know, certain types of diagnoses as well as patients in order for them to heal and have the best outcome. Okay, so now we're going to do a little other category. I'd like you to consider and think what these substances are that we have seen occluding our PICCs and tunneled devices. So on the left, the bright yellow neon greeny solution is antifreeze, which can cause severe kidney injury. And the patient that showed up with this initially a few years ago had to go on hemodialysis right away. The second one is cough syrup or NyQuil. Again, a very sticky, thick substance that obviously would be an issue in any type of line, whether it's polyurethane or silicone. The third substance is crystal meth. And again, because of its hard crystallization, rocky substance properties, it absolutely will cause damage to the lines. We do still see and use silicone lines, so this can actually be quite jagged and cause tears, micro tears in silicone lines. And the last one, which is the white substance here, is crack cocaine. And what the patient has tried to do here is liquefy it. And again, it actually hardens like a rock physically in a small 5 or 4 French lumen. So when we think about, again, patients that are using substances, it really could be anything. It could be cough syrup, it could be antifreeze. There could be something else out there that I have not seen yet in my emergency department, but these are 4 very common ones, unfortunately. Actually, not the antifreeze, but you know, the other 3 that we see quite a bit. So I'm going to dive now deep into local strategies here in Vancouver, BC. My hospital is right downtown, very close to ground zero of many issues with homelessness and some of the self-injection sites and overdose prevention sites. So what we feel is the benefit is that we are in a very convenient location and we have a team that is highly focused and highly specialized in harm reduction awareness. And I think that really is important in terms of, especially when you're a busy emergency department that sees a very large influx and outflux of patients. And within our emergency department, we, again, work very closely with security because at times when we're trying to initially deal with an acute situation, they are the people that really help us in terms of managing the environment and keeping everybody safe, the patients as well as the staff members. Our inpatient unit, we work very closely with once a patient is identified that comes into the emergency department. Their focus is, and their specialty is in urban health. And then again, of course, the nurse team and the addictions consult team. So this is Tanya, the clinical nurse leader that I work very closely with in the emergency department.
Tanya Campbell says watching the same people come back again and again is overwhelming.
Can we get you to come off the stretcher?
But she always has a smile and a kind word for all her patients.
Do you worry that there's going to come a time where Narcan's not going to work because of whatever people are taking is just too strong?
I think that's definitely a fear that all of us have as healthcare workers, is one day we're not even going to be able to even try to save these people. And we're going to have, you know, a horrific amount of people dying on the street because they're not quite sure what they're taking.
Have you had the same person come again and again?
Oh yes, yesterday we had someone come back 7 times in one day, getting Narcan in the community or here every single time. It can get overwhelming. It can get to the point where you're just like, why are we doing this? This is getting too much. But at the end of the day, when I actually saw him at the end, he's like, you know, I really need to do something about it. So occasionally you can break through and you can find that one moment. So you just hope.
So for inpatient issues, and I know there's been a lot of talk about this at AVA specifically, about tamper-resistant technology and tamper-resistant controls. We have that on the pump, for example. We have tamper-resistant tape on bottles that come from pharmacy is another example. And then we also have tamper evidence or is it tamper-proof or is it just tamper evidence? We have these devices that could be shown on the lines, usually a PIC or a external tunneled line, that would identify to a healthcare worker or clinician that the line has been tampered with, essentially. So, this is innovation to me and something that I looked at and considered in my hospital. But the question that came to me was, again, remembering that I have a very highly expert team and knowledgeable team about harm reduction and strategies. The question came to me was, well, that's fine, but will you use this on every single patient that has a PIC or an IV or a CVC? My answer obviously is no, purely because of the cost implication. But the answer I got back from risk management was, then why do you want to stigmatize these patients? If you want to bring something in like this, if you really are concerned about tampering with devices, put it on every single patient. So that really made me pause and think about, what is the purpose of it? Is there another way to utilize harm reduction theory and keep these patients safe? So we chose against the tamper evidence device. And we're looking at other strategies. We have a staff safety program. Many of our acute site rooms are very cluttered, and there could be issues of use and sharps and dangerous substances within the cluttered rooms. And as you see here, this is a semi-private room. So in collaboration with occupational health and safety, we have a care plan in place where the patients, once they get admitted to an inpatient unit, there's an agreement for them to dispose of their sharps safely. Sometimes they don't make it to the sharp bin, so we would have just a common agreed place or receptacle for them to put their devices. And this is really to keep staff safe. So what was happening was the food delivery people and even phlebotomists, etc., they were feeling unsafe going into rooms like this to provide the best patient care. So this has really been successful in keeping staff safe, as well as educating and helping to have that discussion with patients that it is not acceptable to have unsafe sharps everywhere or substances, and they should be in a common area where people can see it and dispose of it properly. So again, thinking outside the box, knowing that things are probably happening in the rooms, but how can we keep staff and patients safe? We talked about Narcan, and there were about 40% of you, I believe, that said you do not have access to this. I think it was a very innovative and is a very important strategy for the general public to have access to this. I don't know what the situation is now. When I presented this at AVA last year, some people were coming up to me saying that they do not now have to pay for naloxone, which is excellent. But I really think this strategy will save lives. I think having easy access to this and teaching the general public on how to access and how to use it can literally save lives from overdose. So this, again, is an important public health policy that can be implemented very easily. So on hospital grounds, we also have the Overdose Prevention site. So we don't advocate for people to use in the hospital setting. Sometimes it occurs, sometimes it doesn't. So what we looked at as a strategy is to have this OPS. We have thousands of visits, and we have peer support workers. So they are not nurses, they are not physicians, but they are trained on how to use Narcan, and they can actually, help and be right there and keep the patient safe and actually keep the environment safe around the hospital. So this has been a very important and successful strategy. We also have the OPATs, and I think OPATs are worldwide known as, very successful strategies, as well as home IV antibiotics programs. So this collaboration between the two in terms of having easy access and support in the community, there has to be different options for all patients. Some patients are able to come once or twice a day to the OPAT, and some are not. So having an extensive and comprehensive program in the communities is very important with harm reduction strategies in order to keep everyone safe, not just the patients, but also the staff that are dealing in both areas. So in Vancouver, we have a homelessness problem. The average temperature does not get very cold, does not get very hot. It's a relatively geographically well-spaced area, so we don't have a huge, dense urban population. So we do have homelessness where people, unfortunately, feel the need to be on the street. So this social issue is a whole different realm of a topic that we could talk about. But the important thing to remember here is that all people will be affected by this. It's just not the streets, essentially. In general, the public is affected. So we looked at how we can deal with patients or people suffering from substance use disorder that don't actually have a home. And one of them is the community transitional care team.
CTCT is an acute care clinic in the downtown east side that provides residential care for intravenous drug users who end up in St. Paul's Hospital. Historically, the medical community looks at the drug user and will try to treat the addiction before the actual health complaint. Here, we actually address the health complaint first, and in that process, if someone wants to get to treatment or detox, we'll address that. We also provide wraparound services in housing and advocacy in healthcare. Typical stay here is 6 to 8 weeks. We have never discharged anyone to the streets under any circumstances. People leave here housed and healthy. 96% of our patients complete their antibiotics versus 20% in the hospital. It's a very good thing. We save a lot of tax dollars. There should be 20 CTCTs.
Again, another successful strategy that we've used using an old building that really was decrepit and nobody pours money into this area of the downtown east side. But now we're seeing a rejuvenance of sites that are meant for safe environments. And the CTCT, they want to have these patients stay there, and they will, provide shelter, just the basics, shelter, food, and, unconditional care. Their ultimate goal is when they're on IV antibiotics that they complete it and that they're compliant and that they heal is essentially it. A lot of the patients we see there have cellulitis, so that there's a wound care issue, and everything can be provided in one place. So it provides a safety net for them where they feel safe. They don't feel threatened and they don't feel stigmatized. And what we see here because of that is a huge success in terms of patients that comply and complete therapy. This is another clinic that we have in a similar downtown area where this is patients go there and we provide them with the drugs to inject. The reason why I'm involved is I was helping the nurses on injection technique and vein care, so vessel health and preservation. Really, at my core, I'm trying to teach that to patients and nurses at these clinics. It really was thinking outside the box for me. They wanted to ultimately get rid of the barriers of stigma and judgment. And we know that the illicit drug use was happening. So the cellulitis was also happening because we would see them in the emergency department or the ID clinics. So how can we work together and collaborate? So this is where, I was involved in helping with them. So this is ultimately what happens at the clinic. They actually get sterile supplies and drugs of their, typically it's heroin, and you can see that the area is very clean, it's safe, they're not in the back alley, they're not in the street, they're not using rainwater or saliva to inject. It happens very quickly. It may be hard to watch this, but this is a day in the life at a very important and well-used clinic.
There's anger elsewhere as well. Former Health Minister Rona Ambrose tried to shut the heroin clinic down, saying the goal must be to get heroin out of the hands of addicts. It took an order from BC Supreme Court to keep it open.
So again, what you can see there very quickly is that they are getting a syringe with a needle. They're putting a tourniquet on. I mean, super quick. I can't even put a tourniquet on that quickly with one hand on myself, and injecting, finding a vein and injecting, and then disposing properly. So again, maybe very hard for some of you to view. Unfortunately, this is happening in our downtown east side. So how can we help as vascular access specialists? How can I help? That was the question that came to me. This concerns me because these photos here are taken on the street in a back alley with needles. I don't know if they've been reused, syringes, I don't know where they got them from. It concerns me. So I was brought in to help with vessel preservation. And, I was really trying to help them, some of the clients that come into the clinic on where not to poke, because essentially if they come to me with cellulitis, I don't want their ACF blown away because the lab needs to get blood work, for example. I don't really want their hands and their wrists used. The conversation was about, this is the best way to use a tourniquet. This is, you should scrub and clean with alcohol. Whether they do or not is another thing. They are told to wash their hands. There's hand hygiene strategies in place at all these clinics. So again, using a poster like this that was developed by CVAA, the Canadian Vascular Access Association, actually helped not just the nurses, but also the patients. It's just a visual tool for them to say, okay, I'm going to consider not going in the elbow crease. I'm going to consider not going in the wrist. So every little bit helps, and it's a very small step, but I think the outcomes that we've seen so far have been very promising. So again, putting a tourniquet on with one hand is an amazing skill. The healthcare workers that work there, they actually do not inject the drug into the patient, but they assist maybe with anchoring or location finding. Hand hygiene again is key. They do have access to all sterile single-use supplies. So another thing in progress that we have is in the inpatient unit at the acute site, we are also providing sterile supplies there. So not just at the clinics in the urban centers, but actually on the acute site. Again, trying to think outside the box, we are providing a lot of patient education and trying to teach them how to the one thing we don't want them to use is non-sterile water. The injection of that can be very, very damaging. So breaking down all the barriers and having it there for them. We're just looking into what the statistics are in terms of, are they using more, are they using less? But we have definitely seen less negative outcomes. So again, understanding that the substances that they have, how to mix them, how to inject them safely through the device, always using a needle-free connector. This is the type of patient education that we've had to do. So, very much, if you told me 20 years ago that this is what I'd be doing in my nursing practice, I would not have believed you. But this is what it's come to, and the safest way possible, I think, is our main goal, and we've been able to achieve that. So closing up here, we just need to think about the whole person, not just what's happening in terms of their cellulitis or their vascular access, but what are the factors that have driven them to other things that are affecting their lives in terms of poverty, homelessness, and maybe mental health issues. It could be reality escaping strategy for them. How can we work together in a collaboration with multidisciplines, trying to break down all barriers? So, me using ultrasound and finding that great vein, putting in that pick for that patient is just one tiny aspect of how to, utilize harm reduction strategies and theory in terms to get these patients in a good place. And that good place does not necessarily mean complete abstinence. It just means, a safe environment, safe injection practices, and completion of therapy. I think those small goals put together can really save lives. So in summary, there's a lot of ethical implications in terms of what we do. Some of the video and photos that I've shown may not be aligned in how you think. They weren't aligned in how I used to think. But we are being challenged like never before. So we just have to remember that we have a duty to provide care, and accepting what is happening is very, very important and is one way that we can save lives if we let it. So there's a group of people that have helped me tremendously in terms of, in the work that I do, as well as sustaining the work that we do and really trying to improve practice in Canada here. And I'll just leave you with this finally. So I think substance use disorder, it's very important to realize that it's much more prevalent than we actually believe. So thank you very much.
Jocelyn, thank you. That was a great presentation. So appreciate you.
Camera back on. So let's see here. We've had a frequent flyer who is an IV drug user patient with bilateral upper extremity DVTs. So usually lands a central line when she's admitted for a long stay. Last time she chewed up oxycodone, I'm guessing, and self-injected into her central line with a saline syringe that was left in her room. She had a virtual sitter. Any ideas of how to help manage her while still having empathy for her disease?
I guess first and foremost is try to have that conversation, and I know that may sound obvious, but patient education is very important. So what we would do here is try to have provide them resources in terms of education and just tell them what the risks are and be very blunt with them. Crushing up pills is a very common thing that, as we know, will block the line. And I think a lot of it has to do with explaining to them, you block the line, you have nothing, right? I mean, with bilateral DVTs. And I think what we forget is these patients can understand that. They can understand that if you lose this line, you will have nothing. Trying to get them off the oxycodone into a liquid format sometimes helps. We try to eliminate the risk and the barriers altogether. Those are some of the strategies. It can be very challenging.
Another question for you, Joss. Patient with high suspicion that they've misused their catheter, injecting substances into the line. How do you guys handle that?
So what we do is we would aspirate. Obviously, we would not flush right away. Sometimes that works, sometimes that doesn't. And we would, if the line is not damaged or torn or broken or cracked in any way, if we cannot aspirate, so half the time we can, you would aspirate 10 to 20 mils of blood and hopefully get the substance that's caught in the line. If you have to inject, we would have Narcan on hand and notify the care team that we might have to do this. The other aspect is some people prefer to just take the line out right away, but the vascular access team is usually involved in the decision because sometimes we have worked very hard to get that line in. So if it's that patient that had to go to IR, or, you know, saw the IV team, saw the vascular access team, you know, these patients, sometimes these lines are not easy to replace. So just yanking the line out is not always the right answer. So we typically try to aspirate, we would flush a little, but we would definitely have the care team aware and Narcan on hand.
I think it's very interesting, almost like two different perspectives in care when it comes to vascular access, how it's currently being practiced for IV drug users, where you have a social stigma group, if you will, where, oh, they're an IV drug user, we're not going to be placing any kind of central line, we're not sending them home with a central line. And then you have the other half where, you know, the very realistic picture that no matter what kind of vascular access device you put in a patient, they're going to use it, or, you know, if they don't have anything left for their own personal use. And then how do we bridge that therapy as far as making it work for the patient and for the therapies that we're trying to provide for them. There's an interesting question here too that kind of follow along these lines of what are our liabilities if we place a PIC knowing the patient is going home with it and has a history of drug abuse?
Yeah, that's a great question, and I don't know the answer to that. I think from the clinician practice perspective, we have a duty to I think we're more liable if we choose not to give them the PIC line, for example, and say, I mean, is that based on my judgment? The physician might say they need that. They need it. You need to put it in. And then you said, do you not send them home? Do you keep them in the hospital? I don't know if that's appropriate because they will just go. So I think it's a great question. I think that, you know, liability wise, we should maybe consider asking some of our legal experts on that question. That's a great question.
I think documenting also that you had that conversation and you consented them for safety, that don't use the line, you understand if you do, you can get endocarditis, whatever the case may be, that I think that's an important factor. Does it negate the liability? Maybe not, maybe so, but definitely having that documentation of that specific talk, specifically to you're currently using IV drugs or recently in the past you've been using. And now you have this giant, almost a tease, if you would. It's like giving a alcoholic a bottle of alcohol and saying, this is used to disinfect your foot wound, but don't drink it. You know, we're giving them access into their vein. So that's a tough one. That's a very tough one.
That is a tough one. That's a good question.
You mentioned using an adhesive to help securement. What products have you used for liquid adhesion, and why did they not seem to help you, as you mentioned?
Securement of the line, I think. Securement of the line. So I spoke about the subcutaneous anchoring device that works better for us in terms of, well, we put it on all patients. So every patient gets a subcutaneous anchoring device for their central line. Even the tunneled lines, because we're finding that there's some cuff adherence issues. So we are putting the larger subcutaneous anchoring device for those. I was referring to the adhesive securement devices, not tissue adhesive. So we also do use tissue adhesive with our subcutaneous anchoring device to seal and protect along with that. So I don't know specifically what the question is for.
That was it.
Okay.
Thanks, Joss.
Do you place a PIC? So do you place a PIC for IV drug users when they go home, not just the nursing home? And I'll let you answer that one.
Yeah, we do.
Yeah, it sounds pretty great. And it's interesting because I think in some of the slides I was reading through them was actually like teaching people how to safely access their device. So when they go home, and that goes back to my previous statement, is like, when do we start training patients who are going to use the line to do it safely and, you know, kind of, again, scrub the hub, best practice as far as like cleaning and maintaining the line. Because we teach people how to do dressing changes all the time. we teach people how to do saline flushes, how to attach their own IV pump. I mean, is it really the purpose of like using your own, how to safely prepare a medication for administration? You know, I guess the, you know, up to.
And I think that was the real challenge is you know, the stigma around that was, you know, what are you mixing? Are you mixing ANSEF or are you mixing, you know, an illicit substance, which, you know, they really are two different things. I'm not trying to, you know, decrease the severity of that, but it really comes down to, as a clinician and teaching, like you say, best and safe practice, obviously hand hygiene. And, you know, I mean, that in itself, as we're learning with COVID, you know, hand hygiene is essential for all the foundation and the core of our clinical practice. So teaching patients that, because you're going to teach all patients that. You're going to teach all patients how to use that syringe and how to access that catheter regardless. So I think what I had to wrap my head around was I have to do that for every patient, not just certain patients, right? Every patient deserves that education.
Well, look at the survey we did earlier, Josh, that said that we have, almost all of us know somebody, love someone that have issues with the substance. And, you know, by the grace of God, we're not in that boat. So I commend you guys. Now, in question from Sally, one of our attendees, in that Crosstown Clinic that you mentioned, are they also in a program to try to stop use? Or does it matter?
So they do have support systems in place there where, you know, recovery support services. So whether it's through abstinence or through phasing out of, because you don't want them to go into withdrawal. I mean, there's many things that occur within the whole journey. So at the Crosstown Clinic, they have access to all support services.
That's nice. You guys are you're very progressive.
Yes, I think what we saw here was, you know, it was a health crisis. And it was deemed, you know, an emergency situation where we have to really open our eyes to this and face the realities. So it's been many years now that Vancouver has really been trying to think outside the box and utilize a lot of different strategies.
It does look like we have a couple questions basically around devices or tools used to prevent patients doing self-access. Is there a tool that you use specifically for that, or have you seen or heard of anything that's worked well?
Well, what I saw at AVA last year was a clamp that sits onto the lumen of the line. And I think there's another one for IV tubing if they were connected to an ambulatory pump, for example. We did not find them effective. We didn't find them cost effective either. So I guess the issue is it is only tamper evident, not tamper proof. Because the reality is that if they're going to access their lining appropriately, they're going to do it, whether there's a clamp on it or not. I feel, and, you know, as a team leader, I really, you know, decided that I felt that they would do more damage to the line trying to break through a tamper evident device versus using the line inappropriately. The damage to those lines, you know, and I had a slide there with whose line is it anyways? We do take it personally almost. You know, when we've worked so hard to get that line in, and, you know, I just don't want them fiddling with it. I don't want the tamper evidence because the evidence really means nothing. I need to be able to move forward and either help the patient understand what they've done, try to repair the line or whatever. But, you know, it's not tamper proof is the whole point. It's still going to lead to some sort of damage to that line and the vein, essentially. Did you find that they were, like, when the tamper resistance piece failed, that it damaged the line that was inserted? Well, it would just, we didn't use them for very long. I think we only tried, you know, just for a very, very short time. We just found that once it was evident, that the question still was, well, now what do we do? Are we going to take the line out? Are we going to stop treatment? Are we going to, the same questions still came up, even if they came in and they disclosed to us that they used it, or it became, obvious they used it with a needle-free connector or a little hole in the catheter. I think in spite of a device that provides the evidence that they've used it, you still have to go through the questions of what he's going to do.
If that patient has an occlusion caused by drug, precipitate, whatever they've used, how many times do you replace that line, or is there a number? I mean, what do you do?
There isn't. So there is no magic number. We would just replace it over and over again. And eventually what happens, as we know as vascular access specialists, is their vessels deplete. And suddenly we are, the risk goes up for things like DVT and occlusion and stenosis, and your options go down. So, but we would still try to replace it. And we have a very close relationship with interventional radiology and vascular surgery also.
Perfect.
Do you feel that there are differences in healthcare systems in Canada versus the US that help support these programs or clinics? Do you think that it could be supported in the US more?
Well, I think absolutely and completely there's a difference. Our healthcare systems are very different. And I really would encourage vascular access specialists to try to be the voice of reason and what the evidence is out there about harm reduction. It's just not Vancouver. It's countries like Portugal and countries in Scandinavia that have utilized these types of strategies. And I think there is opportunity in the U.S. to be innovative and try to use these strategies. I know that there's a different health crisis happening right now, but absolutely. I don't think we should close our minds off and think it's only happening in Canada or it's only happening in Scandinavia. I really think that we could be the voice of that as vascular access specialists, because we're the ones that see the bad outcomes, and we're the ones that they demand us to get that line in for them to give the therapy. So, I think we have an important position and opportunity to be able to, again, it's baby steps, it's small steps. What can we do to advocate for these patients, for all patients with vascular access issues, right?
Well, you make some really good points. And I think, you're right. Canada and the US, we have drastically different systems, but we have the same patient. And, there's no wall. So we do have the same patients. And I think there's so much more we can do that we're not yet. And as an association, as the group that sees these all the time, I think we need to consider that. Now, we have a liability issue here that you guys don't have the same ones. But
no, that's true. That's true.
There's got to be a way for us to overcome that for compassionate care. That because people are talking about the reimbursement issue if that line gets infected. That's true, but if you have proof of having the line tampered with, I'm not quite sure those same rules stay in place.
So you're saying you wouldn't get reimbursed if it was tampered with?
No, I don't. I think that's an exclusion to the CLABSI. If it's a known, I need to go look that up. I don't want to misspeak. I was actually texting Kelly.
So I deal with this directly in my work right now, and you have to be able to prove it without a doubt that this was something that was tampered with. And but the problem is, like, someone's still getting a CLABSI, whether you're reporting it or not.
Yes.
That's true.
Yeah.
But if it's holding someone from actually going to do the most compassionate thing, then we need a workaround.
Right.
I think.
So reimbursement driven stuff.
The reimbursement, and also the cost of the devices and that. So there's a lot of things we'd have to jump over to get to this, but I think it's very thought provoking. So what would you recommend if you had your wish list and things that we could go do? How do you see this expanding?
You mean in like a baby step for you guys?
Baby steps, because baby steps.
Baby steps, small little steps. I think with the healthcare system differences, I think really having that discussion. Don't be afraid to have the discussion with the healthcare team and the patient, the client themselves, because most of the time that client or that patient will surprise you. I think that is the number one issue that I had ethically, based on my own personal, judgments and thoughts, is that I was taking these people for granted. Having a detailed conversation and very blunt conversation with them, they understand, and you can put, this could be any patient on IV antibiotics. You're going to talk to them about the risks and the benefits and the disadvantages of using, and what this can do to your life. I think my number one thing would be is to have that conversation with all patients, and do not, silo a certain type of patient. If you are assuming they use IV drugs or substances, have that conversation with them and tell them how important that line is. Tell them how important their veins are, because there's a lot of peripheral IV access, right? It's just not about using their PICC. It's also like I showed you, those patients that are poking multiple times. That leads to the cellulitis, that leads to the PICC line. But if we can back up and say, don't poke your vein multiple times without cleaning with, you need to back up. We're already at the phase where they've got a central line sometimes, but maybe if we, focus on prevention strategies and before getting the cellulitis, before getting the endocarditis, I think that, again, very small steps. And just have that conversation and patient education.
And it's interesting. So we've talked about social stigma and reducing that.
Mm-hmm.
Why should everyone have a tamper or non-use device if they're not IV drug users? Is a question from the audience. And shouldn't the users be the only ones that have the device? And I think that's really the piece here is, if you are suspected of using a line and not caring for it correctly or using it for substances, that's when you would use it. But I guess my question for you would be is, by using this, does that change the dialogue that you're having with your patients when you were using them before? Did it increase the stigma? Did it increase the resistance?
Absolutely. Yeah, absolutely increase the stigma. Yeah. I mean, personally, many years ago, I had a patient who, looked like the woman on the screen here, like the sister, daughter, and friend. And, I think we have this vision of what a IV drug user or substance use disorder patient would be, homelessness, poverty, etc. But I mean, I guess the whole thing is, yes, I guess I could bring in the tamper evident device, but I would put it on every single patient. I think it's very difficult to know. And it's fair to say that you do not know if they're going to use the line inappropriately. And if you think about all the PICCs that you insert and all the IVADs and CVCs, and maybe 50% of them go home, maybe 25% of them go home, but every one of those patients, you don't know what they're doing. You just don't know. So sure, we could put them on every single patient, but I don't think isolating a cohort of patients based on your assumptions, whether they identify or not identify, is really fair. I don't think it's ethical. That would be that's my opinion.
Okay, Joss, last question for you. Success rates. Mm-hmm. What is the success rate of these clients from the Crosstown Clinic, and in the time frame? And are you just giving the drug, like giving insulin to the patient? And sorry, I have to move the question so I can read it all. How is the client, or what is the criteria for ending the program? But the bottom line is, what's the success rate?
So I don't have the most recent data or statistic points for that. It is obviously a government-funded clinic. So I'm sorry, I don't have that offhand. What I do know is that the criteria for approval to enter the clinic or become a clinic person is quite lax. I mean, I think they have to be seen by a physician. There obviously has to be a known substance use history. And what we do give is the nurses or the clinicians there are not actually injecting the heroin into the vein or into the patient, or even poking. It is actually the person doing that. The patient is actually doing it. So we do not have any hands on that piece. So when I went in there to talk to clients of that clinic, I showed them the poster. You know, we looked at their arms. I said, I don't want you to go here or here. I just, try to look here and maybe the hand. So it's not really a direct patient hands-on care clinic. And I'm sorry, I don't have the current data on the success rate.
No worries. Joss, this has been great. I appreciate you and your time. Thanks for joining us.
Thank you.
One of my favorite cities in the world. So hope to see you on our next webinar. Bye, everybody. Thank you.
Thanks, everybody. Be safe.
Be safe. Bye.